Good morning and welcome from all around the world to Structural Heart Live Cases broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I will be your moderator today. We would love to hear from you, so please send us your questions directly from the website or on YouTube. And remember, you can review all our previous Structural Heart Live cases at ccclivecases.org. And let me transfer now to the cath lab for an amazing case.
All right, Pedro and our viewers of structural live cases and CCC live cases, thanks to all. And we try to show, of course, sometimes complex and sometimes our own, I would not call it a mistake, but the judgment that could we have done something different. And that led to this case particularly. And we are not ashamed or afraid. A lot of people don't want to show their questionable outcomes, but we are here to show this very interesting case who just lasted TAVR 1 year. Exactly 1 year or maybe 13 months, and what we could have done differently, we go through that. With that note, I want to introduce my faculty. Go back again once, Dr. Gilbert Tang, Dr. Keeney, Dr. Huda, and of course 2 fellows. We have Pratish and Gaurav. So with that note and rest of the cath lab staff, and on the echo, on the echo is Dr. Larakas, who will guide us, and anesthesia, Dr. Fang. With that note, let's start presentation of this case. Basically, these are our usual. Give 2,000 more. Yeah. So this is the patient of the redo TAVR with 36 millimeter Sapien Resilia for severe PVL in the Evolut Valve. So very interesting. That the 79-year-old patient, progressive shortness of breath. Patient had a TAVR in April 2025. And risk factors are there, little CKD, creatinine about 1.8. Not a really very heart failure type. I mean, very bad kidney disease point or hemodialysis, but high. It does have metastatic prostate CA that made him high risk even last time because on treatment. And now patient presented in last few weeks with a severe paravalvular leak, and we are going to show you the serial echoes when we deployed 1 month, I mean day, next day, 1 month, and then of course now. Patient is a good medical therapy, is in sinus rhythm, and patient had a bypass surgery, the 2 vessel graft, 1 graft occluded, but rest coronary point of view has done fine. So this is the echo which we have post procedure, but we'll get this was done immediate post TAVR procedure last time, and you can see here this looks like maybe Stem, you can comment on it?
Yes, minimal PVL, as you can see.
Minimal PVL.
Anteriorly, yes.
Beautiful. Now, this is the next day after the TAVR. So now we are talking about the 4/25. So next day, this is what we have still remain read as a mild PVL. Now, as you know, all patients come as a part of the TVT registry 30-day. With examination, blood test, and repeat echo. And here they read as multiple jets, but there's an overall still was the mild mild PVL.
Yes, yes.
Okay, so that's where we are. And now, of course, this is now we are here today, or means just few days ago when we have this echo showing severe paravalvular aortic regurgitation, so PVL, severe PVL, and I'll just let now Stem Larakas to just talk about actual on today. So let's get the live echo from today, please.
Yes, thank you, Dr. Sharma. So as you can see here, this is the left lateral appendage that appears clear. This is the mitral valve focus with normal LV function, mild mitral regurgitation, mild tricuspid regurgitation, minimal PI, and this is the long axis mid-esophageal view of the Evolut Valve. As you can see, a significant anterior PVL, as you can see coming out here. And this is playing with the probe. The patient has also a small posterior, as you can see here, but the major PVL is anterior. Again, the beginning and the end, this comes out in the LVOT. This you have to measure to severe PVL. And as you can see here, this is X-plane, and you can see that the origination of the jet is about 8 to 9 o'clock, anterior 8 to 9 o'clock, as you can see here. And this deep gastric shows everything. The anterior PVL, as you can see on the right, severe. mild posterior PVL in the other side, and minimal valvular aortic regurgitation. These are the gradients, no significant gradient, mean gradient of 11. And this is the area, actually the one way to find out the severity is area of the PVL compared to the area of the TAVI, and it's 54%, above 30% is severe PVL. So no doubt it's severe and no pericardial effusion. Thank you very much.
And EF, ejection fraction?
Yeah, ejection fraction normal.
Good. Now, second question, which is important one, can you see, can you on echo, of course we'll show the CT, you think on echo, can you say that the valve descended compared to what was there last year?
I think the valve was deep into the LVOT from the beginning.
Now, is there any recoil? Of course, we go to the CT, but those are the two important factors, that there is a recoil of the valve migrated and down. So let's go back to our severe paravalvular leak. We go to our presentation. This all has been done from 9 to 11 o'clock position, which just mentioned on focal now. Gilbert, is all yours now. CT. Our CT, the first one.
Right. So this is the first one. You can see it was appropriately sized to a 29 Evolut, but because the deep implant, the waist of the Evolut will not seal against the native anatomy. You can see that here, and you look at the native anatomy also is big. You can see it's trileaflet calcified anatomy. High left main, high right coronary. So, I think TAV and TAV will be fine, but unfortunately this valve, and we'll show you exactly what happened fluoroscopically. So this was the initial view.
Coplanar view, and that is what usually we do, so that we can see that valve height and in relationship with the left main.
Yeah, next slide. So this is the initial deployment. You can see it was pretty good. This is the, I think they just...
Can we press it, play?
Does this play? Or this is
Guys, can you play? I mean, we put it there.
No, this is not play.
There you go.
It's doing.
So you can see this is the first time.
Yeah.
Right?
Yeah.
And then if you
so
go to the next
really
slide.
Deep.
Yeah, so we'll recapture.
Yeah. And then can we play it once again? The repositioned it. See that? It looks good here.
Yeah. So
this could not have gone further down. I mean, really adjusted, and then it was released.
Yeah.
And now you see there. It descended again.
Yeah. So it dropped during release, unfortunately. Yeah. So next slide.
So then question was, then we did a post dilatation,
right,
and you saw the echo. Everybody was happy. Not, I would say, we didn't get an A+, but we were so happy with like a B2+ situation, that we did okay, good in this case, and there's no need to retrieve it or put an additional valve in a valve, and hemodynamics still looks good. So we left that at that time. So this is that then issue always comes, was it a commissioner non-alignment, which can also cause a valve degeneration, but there is no valve degeneration. It is all PVL. So you want to comment on this?
So good commissioner alignment, at least. So in terms of TAV in TAV, we'll make it a little bit more feasible. Next slide. So this is what we look at now in terms of sizing. I think it's critical now because the valve is deep. So it's not a traditional sizing of the mechanism paravalvular leak. So you can't just go by in vivo sizing. So if you look at us, we typically stop at node 6, but because it's deep implant, you need to go higher to figure out there are 10 nodes on the Evolut, 29 Evolut. So when you look at the average area, from 3 to 7, which is roughly where the new valve should land, is around 423. From 2 to 6, all around the same. But you have to oversize. You have to oversize for two reasons. One is anchor, because the native anatomy was actually would have sized for 26 Sapien. And two, you say you have to fix the PVL. If you just put a 23 at volume, you will not do anything to this problem. So I think this is something very critical for the audience out there. Depends on the mechanism failure. Most TAVR fail by either AS or AR or mixed AS-AR. We have two state-of-the-art papers coming out in Jack Little mentioned in New York Valves in 2 weeks that I was leading. So we'll tell you exactly how to treat. But for paravalvular leak, it's totally different ballgame. Next slide.
Beautiful. Okay. So therefore,
so because the deep implant, no issue coronary obstruction. So next slide, you can see.
So basically, as you know, the new terminology for the valve in valve or redo TAVR is basically one we call it the neo-skirt plane, which will be the top leaflet of your original valve, and secondly, the coronary risk plane, where are the coronaries are originating. And therefore, this clearly you want a coronary risk plane above the NSP. And if they're below, then you have to worry about do either leaflet modification or preempting the ostium of the of the coronary ostia. So this is what you see, Gilbert. You felt go to node 7 for
Yeah.
the optimal position.
Yeah, and Dr. Kinney will show you how to actually look at it even on the angiogram standpoint, because you need to look at both.
Sure.
You just can't count this because some people get the difficulty counting, or if the patient start crashing, you have to just put it in, safely. So Dr. Kinney will show us that, but this is at least on CT.
Yeah.
You can get an estimate where you want to ideally land it, because you have to seal against the annulus in this case, because the leak is right at the annulus and outflow tract. So if you implant this too high, you haven't done anyone any favor. And you don't want it to be deep, because if flared out, you can risk ventricular migration, because we're oversized.
Yeah.
So anyway, so that's I think that's the
same
next
thing.
slide. Yeah. So
and
abscess
access-wise, fine.
Amit, any
and
comment?
we are going to show
Yeah.
access. Amit, anything unusual we need to worry about?
No, Dr. Sharma, it was straightforward access. Mild calcium, we use pre-close on the right side and accepted as main.
Using a two pre-close or one pre-close and one?
Two pre-close.
Two
like,
pre-closes, okay. All right, so this basically summary of the case, that this is, we have the transfemoral tower, or we call redo a TAV, in using 26 millimeter Sapien Resilia in failed 29 millimeter Evolut FX plus. So Anu, you have taken some pictures. Teach us now what is going on there. Go to the, good.
Go back to the original question. When we placed this valve, right?
Yeah.
We both were there, myself, Gilbert. So let's go back. What do you think the reason that there was migration of this valve into
Patient
the
had
LV?
enough calcium. It was not the patient did not have calcium.
No, I think the annular calcium was not there. A little bit leaflet
The
calcium.
leaflet calcium was there. I think it's just
That's
the
it.
tension
No
in the system.
annular
The tension in the
calcium,
system.
and that's what we are seeing. If there's no annular calcium, especially with this newer generation, the self-expanding valve, you see migration
It can be
moving
more
either
challenging to
go down or up, and we have shown that in one of our live cases also that that's been happening.
Recently, yes.
Yes. So if you see the aortogram, you can see that, right?
And show the hemodynamics also below, please, there.
Yeah.
Yeah.
Show the hemodynamics.
Tell us
So
what is going on and what node you are having.
I actually don't go with the node. I just go with the original.
Dr. Kinney, show them the paravalvular leak. It's actually very nice
you can
here.
see that. You can see the paravalvular leak.
On the left side of the screen.
Yeah.
Just keep it playing and you see the jet.
But here, if you
Yeah.
can see the original annulus, right?
Mm-hmm.
If you see the original annulus, that's what we are going to place the Sapien the way we would have done it, taking into account that this valve does
Without
not
the original
exist.
valve, yeah.
That's what I go with, but I know.
No, but that's
discussion.
important. No, that's important. So you go two ways. If it's paravalvular leak, and the first valve is implant deep, don't go by the reference on the first valve necessarily. You have to correlate the native anatomy. That's why you always get the pre-index TAVR CT. Dr. Kinney, Dr. Sharma, Amit and I will always reference two things. You can't have just one thing, because your eyes might play games with you and you might actually get fooled. So it's very important to do both, actually, in this kind of situation.
Good.
Yeah.
Now let me ask you, knowing that we don't, the coronaries have been done, but patient has a bypass graft anyway, but more importantly also, knowing that we are not aware, we do not know the long-term results of the redo tower. We know for first 2-3 years we'll do fine. The question is, what if the strategy of, although it's 1 year now, can we still pull it up? The original FX valve?
So if you go back to the aortogram, Dr. Kinney, you can show the issue is that there's already endothelialization against the aorta. Okay, so if you look back, just go play the aortogram that you just showed just now.
So 1 year there. What about if they would have noted at 3 months, knowing that endothelialization
it takes
is
about
not...
6 to 8 weeks, right? When we talked about, the mitral clip of Pascal, when they endothelialize with the mitral valve. Same thing with the, these kind of situation, that if you take this out right now in the operating room, you'll be completely endothelialized. Right. Okay. So to pull this would be risky in terms. Also, you see the outflow of the crowns are hugging against the other. You can risk aortic dissection, right?
I see.
I think if you forcefully pull it up. So TAV and TAV is probably the safest in this case, because coronary obstruction risk is low.
Yep.
The option to address the P other than surgery.
Okay. So other point is, if this we would have noted on April when we are deploying the valve, we would have done something which was not there. Means that time it was not that deep. It was about 4 millimeter and was only mild. But if this would have been noted, let's say today, we just deployed this valve. What else can we do to optimize our hemodynamics, valve hemodynamics in this case? Let's say we just did it 5 minutes ago.
I mean, the same concern happens with the aortic dissection. That's would be my major risk to snare it. We might just end up doing exactly what we're just doing now for the second valve. I don't think we can do a whole lot more.
Okay.
Yeah, exactly. I think I will agree with the concur with the what Gilbert Tang is saying. If you see how the top of the valve is, when we try to snare it, if everybody can follow, there is a risk of injuring the aorta in this particular case.
And
In
we
many
have done
cases, we have done it, but the
but not successful. So 2 times we held it, left
then
it, and within,
release it.
as soon as we release the thing, the valve dipped down again. So therefore, everybody believes that if this happens, what we are doing today should have been done last year, but this don't happen on that day. Because we have the good aortogram. We
Well,
showed
but mild
everybody.
PVL, I don't think we should, because
Yeah.
the risk of, like you said, the second valve is not benign.
Yeah, exactly.
Right, in terms of it's might be underexpanded, and if some other issue comes in terms of migration, then you're in a much bigger bind.
Okay. All
So
right.
the only reason why we're treating this today is because patient has progressed
Yep.
to severe paravalvular, and moderate severe is definitely not ideal, right?
okay.
So you want to tell them about
Give me
crossing?
my key.
Okay, go back now. Question comes, how do you cross the TAVR valve? It's usually very easy. You try to use a pigtail itself. You see that? We go back with the pigtail. The pigtail is there. And just use a J wire. It will just get into the LV. You don't, it's need AR2 or any kind of a straight wire to actually cross. And why pigtail is necessary? Because you want to make sure you are not behind the valve. You are in the center of the valve. That way pigtail and J wire helps you to be in the center of the valve and get into the LV. It's usually very easy. Rare cases when we know that there is stenosed TAVR valve, which we are seeing, which is like a 9-year, 10-year-old TAVR valve, that is, those kind of cases, then you may need not AR2, you may need a smaller AR, which is AR1 to cross.
Dr. Kidney, for our viewers' benefit, now looking back, do you think any other platform may have done better job here, like initial index valve deployment?
Yeah, could it be the balloon expandable valve?
Yeah, just skirt is ventricular, right? Just check.
Yeah, skirt is good.
Like I mentioned earlier, when you have when there is absence of annular calcium and there is only leaflet calcium.
Can you dim the lights, please?
Is this something we've been noticing with the newer change in their backbone?
The spine?
Yeah, spine,
Hard
right?
to know.
Good.
Yeah.
Now I'm getting the valve down. Other thing of if we wanted to place the valve acutely when we did the original self-expanding, you have to be also careful of getting the second valve in, that it can this self-expanding first place TAVR valve can migrate into the LV cavity. So careful. I'm going to
Flex
fully
more.
flex.
So Dr. Kinney had an excellent point. So, an acute situation, you don't want to push this and actually push the valve more ventricular. Good. See?
So when we are doing this kind of maneuvers, there's a chance that the original valve, so you need to
Okay, let me go to the view.
anchor and hold it when you're going with the second valve.
Good. Okay, so let's look at the view.
And I'm going to get the pigtail here.
The pigtail, yep. So the pigtail is very important here because we want to see where the coronaries take off is. Some people just count the numbers, but you need to really see it. Okay, 10-10, please.
Okay, let me get into the cavity there.
You want a wire?
Yeah, I think I need the wire.
Oh, it's looped around the catheter.
Okay, let me get in.
There you go. Okay, good.
Okay. Can you see?
Yeah, there's a lot of AR, right? Remember PVL. So.
Now you have to pull back, I think a little bit up. Okay, good.
Yeah, this is
Good.
yeah. So
180. We can leave the pigtail?
Yeah, leave the pigtail for now. Can we test? Is it not working? Not capturing? 120? 120? 150? Okay, good.
180.
Okay, good. Okay.
Okay.
Yeah.
Off.
Yeah, good.
I think this is good, right?
Yeah, I think it's good. No high.
everybody looks at the native valve.
annulus, right? Native annulus.
Yes, I'm looking at the native annulus, right?
Yeah. Pigtail back.
Good. Okay, good. 180.
Okay, Sinatus. Lungs down, please. Lung 20 first. No, 120 first. 120 first.
He did.
No, but
120.
he was too fast. 120. Don't change. Let us tell you when to change. 150. No, lungs back up. It's not the TVP somehow is not capturing. Back up.
Okay, go down.
It should be in, right?
Yes. Try now.
Let's try 120. Okay, 150. No, somehow it broke. Okay.
Is your connection okay? Because it's pacing and then it goes away.
Can we
Just
check
check
the
the
connection
connections. Yeah. Doesn't.
One time it came off.
Yeah.
Okay, try. Go 180.
Otherwise, we need a new box. There's no battery issue, right?
Okay, keep going.
Okay, lungs down, please. Okay, Sydney. Keep pacing.
We're down to 8, okay?
Keep pacing. Back up, lungs back up. Lungs back up.
You know how high you went?
Yeah. Good, that's good.
Okay. Okay, let's check a cine.
Okay. Good. Ready? Well, definitely no PVL on that side. That was there before. That's a good sign. Let's hit it again. One more CC.
Yeah.
One more CC, it was already 8.
Yeah, one more CC. It's okay.
Oh.
Yes. Remember, this is PVL. I don't want recoil and then have a leak again.
Yeah, but then why you didn't go with the bigger size valve?
No,
Huh?
this is a bigger. Yeah, it's already bigger.
Okay, go.
It was a,
Put some color.
it's a 26.
29.
Okay.
Okay,
No,
180.
Oh, man.
Okay. Well, let's do 120 first. 120 first. Sorry.
How does it look? Better or no?
150. 180. Lungs down, please.
More than 8.
Yeah, good. That's fine. This is frame to frame. It's okay. Keep pacing. Keep pacing. Back up. Lungs back up. Okay, let's get a pigtail, please. Lower cap. Mid.
Yeah.
What does it look like? Okay,
Yeah.
better.
Looks better, yeah. I think
Go ahead, Sam. You can take a look. Thank you.
I think what we see is through the wire, But
Yep. Just 1 minute, Sam. We'll go put a pigtail in there.
I have the wire.
You got wire?
Yeah.
Thank you.
Pigtail.
Let me.
Okay,
Sorry.
okay, good.
Wait, okay.
Why is this tough?
wire is out, eh?
No, not yet.
Not yet.
Any questions, Pedro Moreno?
No questions
Yeah.
yet.
Wire
It's
is
out.
anyway.
Oh, it came out. The wire came out. Okay, we can recross. No problem.
You want?
Yeah, we should do some
There was no
hemodynamics.
gradient.
To the color off, the color.
No? It's mostly PVL.
Yeah, we have one question. Somebody saying high risk coronary obstruction. Have you performed the basilica procedure?
Well,
Are they
so-
asking for this case or any case?
Yeah.
I think I think it's related to this case. Yeah.
No, remember we showed the slide, the coronary risk obstruction. The coronaries were higher than
Yeah,
the
here
annular.
coronary risk plane, like Dr. Kinney mentioned, was higher than our neosphere.
the slide we showed. So in this particular case, there's no risk. That's number one. In this particular case also, patient has a lima.
Good.
There's a vein graft to the OM. And only we have to worry if at all will be the right coronary artery. But the height of the right coronary artery was good. There was no risk for
As you can
coronary
see-
obstruction. Going back to have we done basilica? Yes, we have done basilica in This
Okay,
is the
all
TAVR
right,
valve.
zero,
Most of
please.
the cases we have done
You put X-ray,
is
X-ray.
native versus surgical valve. And
color,
now,
flow
of
color.
course, although we have not shown, then there's a device called shortcut device. We have not shown in our
Some color, no?
webcast, but we have shown
Magnify a
during
bit,
our
magnify.
symposium last year. But that device, there is some learning curve, but more important is very expensive.
Okay, let's take a look.
Minimal,
So-
prof. Minimal.
Probably
Great,
just
thank you, Stan.
Yeah.
doing.
So this is the him that looks okay.
Yes, you can see the
Yeah,
hemodynamics.
no gradient. Okay, so let me pull this
So
up.
other leaflet modification, I think, is something
There, see?
people
So-
have to learn
Yeah.
and try to use
Okay.
it.
So some
take
people
that
use, it depends on the alignment.
put
If
the-
you're not aligned, you cannot do anything. Unfortunately, you have to just protect the coronary.
Yeah.
Great. There is another
And
question.
bigger.
They're
Look at the
asking,
box, the box.
we are in which chamber?
Sorry, what does that mean,
Which
Dr.
chamber?
Moreno?
We are in LV, left ventricle,
Yeah.
and then we are
Because it's
also,
coming out here.
in the aorta. So it is LV and aorta. Yeah.
Thank you.
Okay. Anything else? So I think let's just
Minimal.
review here while we wait for
Minimal
Dr.
PVL.
Sharma's
So
presentation.
what is important is in
Measure
this
gradient.
case, we used this pigtail and went with the native annulus. How we would have placed a self-expanding, balloon expandable valve in if this valve, the previous tower valve did not exist.
good
So
much.
that's how you look at it. You see that the pigtail usually has to be in the non-coronary cusp, but you can see that it's in the right. And the way the Sapien is facing, 70-30 almost, right? Or
And
maybe
now you
60-40.
actually,
Yeah.
no, it's perfect. It's like
Yeah.
100
And look at the
zeros.
positioning of this
Yeah.
Sapien.
Yeah.
Now, Anu,
If-
let me ask you, in
You
the
take this, yeah, please take
previous
that,
aortogram, you can see
Yeah,
the
measure, yeah.
RCA very well.
Yes.
Here,
That's way,
here,
yeah.
you can see it very well.
Okay.
Now, look at your aortogram now after the deployment.
You can
Still
still
there?
see it. Yeah,
Yeah.
you
Still
still
there.
see it.
Yeah.
And you can see the EKG. You can
Color, color.
Also, remember, Dr. Moreno, this valve,
Decrease the pacing rate.
commissures only go up to no 6. And you saw in the CT scan, both are well below the coronary. That's what Dr. Sharma earlier talked about. The coronary risk plane, the
beautiful.
CRP is
Explain
above the NSP. So it will never have any issue in terms of coronary obstruction. So we don't even worry about it. So it's not possible.
Okay. So we have completely switched
Yeah.
off the pacer and look at the native EKG looks fine.
Okay.
So there's no way there is any coronary obstruction.
Sam, probe up when you have a chance, please.
Yeah.
You want to go out?
Probe up, please. when
The
you
way
have
the
a chance.
hemodynamics are, there is no coronary obstruction
See
at
the
all.
aorta, come on.
But at the same time, don't go trying to engage coronaries if it's not indicated.
Aorta come out, finish up.
Okay, we're going to do one final aortogram just for all the audience where everything is.
Coming out, it's okay?
Yeah, thank you.
You are happy?
Yeah, very good, yeah.
Yeah.
Okay,
Trivial.
super
trivial.
happy.
Trivial,
Gradient,
if any.
gradient is okay?
Trivial, yeah.
Gradient is good?
Yeah.
Give me a flush.
Dr. Kinney,
Ah.
for our audience, do you have any tips and tricks? Because now they're going to encounter this TAV in TAV in their practice in future. Like how you navigate the coronary engagement in these cases. You know, we try to align, but sometimes it doesn't happen. So how you navigate in your practice?
Great job, great job.
I mean, that's a very interesting question, and that's, I think, what Pedro Moreno was
Let me help you,
also.
let me help you. Let me help
Or
you.
see that?
Where's the...
Looks very good.
Yeah. Use a smaller catheter size and just try to engage the way we normally did. But we'll need upgrade in the app now
Yes,
because we only had one tower. Now we have tower, TAV in TAV.
40 protamine?
Now he's asking TAV in
yeah.
TAV engagement. Of course, it will be very challenging. Yeah.
So, but Dr. Kinney's point in this final aortogram is important. You know, look at, basically we plan it like as we're doing a native TAVR. When the first valve is deep, you don't just go by the nodes. We count them just, to make sure we don't obstruct the coronary. But deep implant usually is not the issue for coronary.
Yeah.
It's the migration and anchoring. And you can see you need to land it exactly where we just did. If you go higher, you're going to miss the annulus and you haven't fixed the PVL. If you go deeper, you can risk migration.
So clearly the disadvantage of the higher, which is not in this case, is the coronary obstruction.
Right. This
Right,
is not. Yeah, there are two issues with TAV and TAV.
Yeah.
People talk about coronary, but the actual major issue is LV migration.
Right.
We almost had one India case 5 years ago that we have to rescue because of that. That was still early learning. Now we know what to do, so we now know how to prevent that from happening.
And
No,
also,
we were trying to also discuss the same thing. If we were supposed to place a second valve, which was going to be a self balloon expandable valve during the
Acute
index
procedure.
procedure,
Yeah.
You have to be careful.
would be very careful
Not to
because
push the first valve.
the first valve can migrate as we are trying to. I mean, one good thing about balloon expandable Sapien that since we can actually, the way the valve itself, we are able to navigate it through it easier, but we will have to anchor the original valve so it does not migrate.
So to
it's not
Dr.
that
Sharma's
easy.
point, we sometimes have to use a snare to hold it in place before you cross the second valve, especially in the angulation is very, very hard to actually even flex sometimes will not make it with like horizontal route, right? Like we've had seen that before.
okay,
Yeah.
let's
go to
go
the
to
slides.
Presentation.
our presentation now. Because that will be for
You gave protamine already?
redo or aortic valve
How
intervention.
much protamine you want?
So if we can go back
40
to our
they gave.
slide.
Okay,
So this is basically, we'll talk about
I want to hear him.
the mechanism of early
Okay.
tower failure
Okay.
causing bioprosthetic valve degeneration, then systematic planning for redo tower, TAV in TAV procedure, then tower explant and surgical valve replacement versus redo tower. So key is, these are the definitions which we all have to be accustomed to. Bioprosthetic valve dysfunction is a general term. Within there, you have structural valve degeneration and non-structural valve degeneration. Structural valve is problem with the valve. Non-structural valve is PVL, like our case, patient prosthetic mismatch, embolization, and this is the most common cause of the PVL. So if you, then of course thrombosis, endocarditis could happen, which is rare. So 65% of the bioprosthetic valve dysfunction is your structural valve degeneration, and about 35% is the non-structural, most common being the PVL, particularly the case we showed. And then after that, there is a definition like all stage 1, stage 2, stage 3, in terms of how much, whether there is a hemodynamic instability, they have the whole gradient, full classification. And then the question comes is, what is the clinical consequence? Sometimes you can leave it, mild paravalvular leak. And then, of course, it will be more significant. Then you have to do something about it, whether it's like in this particular case, we put a valve in valve, or we just, patient go for surgery and so on and so forth. This is a simple one which we have showed many times in the past. It basically is structural valve degeneration and non-structural valve degeneration. Most of the non-structural valve degeneration, because the PVL, PVL as well as the patient prosthetic mismatch will require, particularly patient prosthetic mismatch definitely will require surgical explant, because you cannot do anything on that. And then of course you have to then enlarge the aortic root and put a bigger valve. Now, PVL can be treated by the redo tower, which like we did. And of course, most of the structural valve degeneration are suitable for do, but some of them we cannot do. And as we emphasize, most important region is coronary obstruction. So if you do a new valve and cause coronary obstruction, even if you do various slicing technique or protection, may be a trouble, and therefore in those cases, you may have to do a redo tower. The surgical valve replacement, because the redo tower could be harmful. So with that note, why this patient develops such an early failure of the tower valve? Valve thrombosis, which is not care in this case, we have all the good CT, cusp rupture and damage to the aortic valve, no accelerated calcification, which happens. We have seen patients with the radiation and hemodialysis, within 12-16 months, patient came back. Endocarditis, which is not in this case, valve migration is there, and was it a valve recoil? Gilbert, what do you think? Anything in terms of, although we have started doing a double tap.
So one thing that you need to understand, the self-expanding is not same radial force for the entire frame.
Yeah.
The strongest radial force for the Evolut is in the inflow portion. So if you implant deep, the radial strength for the annulus is no longer there, especially it tapers in, and you could be undersized for the annulus. So I don't think that we are surprised that probably because of that, you have that radial strength issue, and then because of design, and so you have recoil and more PVL later on.
So this is happening despite the double tap. And I'll come back to the double tap point. And now the question is, what is the region for the bioprosthetic heart valve degeneration is similar to your native valve, with a dystrophic calcification and inflammation. And this is what now many of the trials of the chemical to reduce the valve degeneration is targeting inflammation and decreasing the calcification. Now, one of them is the leaflet calcification, the leaflet which are implanted, there being a special treatment for the decalcification technique with the immunological factor, the chemical factors, and all these leads to good initial hemodynamics, but degeneration do occur. And these are the various, I would say, ongoing techniques which will improve the valve design. Most important is valve design and valve deployment. And of course, everything else is a kind of, say, experimental. And we'll hear more and more in the future for these patients. So this is actually the very, I like this editorial, where the redo TAVR begins at the index procedure. And this is what we need to say, that index procedure optimization. Now, biggest mistake is many times is done that we always worry about the coronaries, particularly with the self-expanding valve, and you want to deploy a little deep. But then what happened? You deploy the deep, but now you have created a different situation. You protect the coronaries. But now the hemodynamics, like in this particular case, happen and paravalvular leak happens. So this is one of the things that we go into the lateral view, a nice frame. You have the left main view we call a coplanar view, where most of the valve, the length, coverage of the left main is all seen, and that is where the valve deployment takes place. The question, and the second question remains that depth and height. And then the third is post-dilatation. Now the double tap, we actually published, and two other operators have published, the double tap, particularly for the balloon expandable, increases the lumen, just like we used to do for the coronary stenting. Double inflation has been shown by OCT that you have better MSA in the stent by using a double inflation, or three actually. Here we double tap. Now we know the data which we had done for the double tap for the balloon expandable. Gilbert, what about the self-expanding? Because self-expanding we are dilating almost every case anyway. So does the double tap helps in those cases also for better valve expansion?
Yeah, I mean, we show that. I think definitely for TAV in TAV, I think people will recognize that now there's some new data going to present New York Valve and other meetings that if you don't, then it will be quite underexpanded. So, and I think that, as you know, lead to degeneration and halt and other issue. But self-expanding valve by in nature is nitinol based, so it recoils as a memory, so you cannot overstretch. That was the Evolut 6-year data issue, that if you overstretch the valve, you can lead to potential leaflet damage. So we cannot do that. You can only go by what the manufacturer recommended size balloon will be.
Okay, so therefore, so then question comes back, knowing that the double dilatation, and now we have the trouble with the Evolut valve after 6-7 years, valve degeneration because of overstretch, and the cases which were overstretched, post-dilated, those are the one had degeneration. So do we still recommend double tap? I'm showing index procedure, not in the valve. Index procedure, double tap in the self-expanding also. We know balloon expandable should be done. We have seen angiographically, and some data people have shown even by the big IVUS, but more importantly, by the CT have been shown that you get a better lumen. But what about the self-expanding double tap?
I think you have to go by the safety of the procedure and the placement of the valve. You never go above IFU now for any self-expanding platform, number one. And number two, you have to make sure you don't cause annular rupture, because that could still be a risk, right? So you have to balance against the anatomy. So we're not advocating routinely doing it, only when it's safe, and especially for lower young risk patients. I don't think you need to do it for a non-nonagenarian or 90-plus-year-old necessarily, unless it's really underexpanded. But certainly we like to do it more routinely because we've seen a difference. We've seen fluoroscopically it does expand better, and we know that from the original paper, any unexpanded valve, self-expanding, balloon expandable, has increased risk of halt and actually mortality with that.
And clearly, the second tap, basically those who are our speaker, listeners who do not understand the double tap, basically means we are not increasing the size of the balloon. When you're increasing the size, it's not called double tap. You are optimizing. Once you are done, deploy the valve. Then same valve, you make sure you take it out without bringing the valve itself, just the balloon. And then, or post-dilatation balloon you're using for self-expanding, the same balloon goes back in and just go to similar, maybe slightly higher pressure, but same balloon, not increase volume, and so that's called double tap. And that has been shown, improve expansion, less deformation, and less eccentricity, which all of them have been associated with subsequent valve degeneration.
Interestingly, one of the newer generation balloon expander in the trial mandate double tap, actually, for the trial, for the optimization. So it depends on a particular specific device.
Yeah. And therefore, the best way to avoid redo TAVR is at the time of TAVR that you optimize all the hemodynamics and don't try to bring the valve too down, worrying about the coronary risk plane, that where the left main is originating and the skull tissue. Oh, so this one guide, this is a very nice paper which I ask everybody to review it for this field, or redo TAV. It's a various terminology being used. Redo TAV because of transcatheter aortic valve procedures. It could be TAVR or could be surgery. So this is very nice, has shown that more and more patients are coming. And we actually have done a handful of cases. We have done live relay this Saturday. One of the Indian meeting, we are also doing another case of the redo TAV. So these things, this disease is there, but that patient is different. That patient had a valve 6-7 years ago, and so this is where whole issue comes down to new terminology, coronary risk plane, where your leaflet will be after the valve deployment, and then where the coronary is originating, then the new skirt plane called NSP. And basically your CRP is above NSP, that is what you want. And for the second TAV. And then of course, association is very important. And then you have to know all these algorithms can be made before you go inside. So Gilbert, tell us a little more on the CT, that is CT enough to tell us that the neo skirt plane will be lower than the coronary plane, or we still have to go for the angiogram and so?
I think CT is the first step. If the risk is low, I don't think that's an issue. I think the issue is when the risk is moderate or high, and CT quality can vary from patient to patient. So if the CT is not good, you cannot just trust the CT. We always do an angiogram like you see here today. Even we do an aortogram, even though we know that one CT is very safe, just to help us understand what's going on. And we still believe angiogram is the best, highest resolution answer in terms of deciding whether to protect, whether to modify the leaflet, or even where to put the valve in at that time of the procedure.
Yeah, so we have done lot short and short and tall valve. Have you done, Anu, we have done any, the tall and tall means Evolut in Evolut? Yes. So why would we do any of those cases, not using the short in those cases? What will be the indication of the not using?
Those are typically acute cases, right? But some people have done tall and tall in chronic cases, especially big root, no coronary issue. It might be easier than a short and tall. In some situations, especially if the first valve is not implanted deep, you just put the second one in the same spot. So it's actually relatively easy in that regard. We've done tall and short. Obviously, the tall and short has the benefit of better hemodynamics because it's supraannular, and that's relatively straightforward to put in. So.
May develop gradient.
Yes,
later on.
We've seen that.
Short in short.
Yeah, but sometimes
best
short
is, I think, tall in short.
Yeah.
Okay, the next best will be short in tall.
Yeah.
That's correct.
Yeah,
absolutely.
and tall in tall, the risk, coronary risk, obstruction is probably very high, or re-engaging. Just, I think, forget about re-engaging.
Now tell us a little more about this commissioner. Our commissioners are very good. So what people should do to get the ideal commissioner alignment at the index procedure?
Yeah, at time zero, the balloon expander, you cannot do it. It's not doable.
Right.
The only Evolut platform has that, not even Avatar. So you just try your best to do it at the time of the thing, and then that's all you can do. At this time, anyway. All the newer generation valve will have commissioner alignment features, so that will be good. But yeah.
So this is another factor which you can modify at time zero to have a better long-term durability of the TAVR program. So very, very important. So key is that it has to be at the right place, and so that your degeneration does not happen. So these are the various guidelines which we have spoken. Basically, go through this. I wanted to just put this together. And of course, the data have shown when you do redo TAVR is good, but the problem is you may create more patient prosthetic mismatch. Every way it is better. Compared to surgical, of course, lower MACE rate, 30-day, 1 year, lower mortality, but the problem will be the patient prosthetic mismatch severe is much higher, almost odd ratio of 4 to 5 times, and particularly when you do a short, the redo TAVR. These are the original data. The mortality used to be 12%, and actually the 30 days, and of course 1 year about 24%. Now that number has become about 1/3. And then redo TAVR registry, which by Raj Makkar, which was presented, basically selected patient, you do a redo TAVR compared to native TAVR, all seems to be similar except few things. One, repeat intervention is still a little higher with the redo TAVR, and residual gradient. You always leave about a 15 to 18 millimeter gradient, and compared to your native TAVR, we leave the gradient in single digits. So this is one of the big issues that happen, and the data are only like maybe 2 or 3 years. We don't have more data of the redo TAVR more than 3 years and so. So this is originally was Gilbert Tang, and Gilbert then assigned one of our attending, Penta, in this very nice explant or redo TAVR surgery. You don't have to remember the acronym. It's a simple word, explant or redo.
Yes,
I'm sure Gilbert must have come with this nice...
we put that registry name
registry,
for purpose.
which is a phenomenal, keep teaching us exactly multinational, and this basically showing that whether it's structural valve degeneration or non-structural valve degeneration, and non-structural, as we said, PVL is a majority of the cause for non-structural valve. And you can see 2/3, 1/3. 2/3 is structural valve degeneration, 1/3 is non-structural valve, of which majority is the PVL, patient prosthetic mismatch requiring intervention, happens in a small number of cases. So also, then when you have a non-structural valve degeneration, it happens very early. Structural valve degeneration happens late. See that about 6 years or 5+ years in the structural valve, non-structural valve about 5.5. Now, whether you are structural or non-structural, whether you decided to do redo TAVR or TAVR explant, outcomes are similar at 1 year. So that basically was the structural valve or non-structural, distinct valve types, reintervention timing, with SVD having a longer time TAVR reintervention, but the failure mechanism did not impact of reintervention type or clinical outcomes in the short study. Then there is another, is basically Sapien-3, redo TAVI. It basically goes through that, yes, can be done safely, what to be used, and overall low complication up to 30 days. And the gradient, yes, as I said, the gradient does happen based on the valve size. With a large valve size of 26 millimeter, the gradient is very low, but a smaller one will have higher gradient. Then shown that redo TAVI with a balloon expandable is safe and effective reintervention strategy when guided by heart team, standardized procedural planning and comprehensive imaging. Key is all these cases require more timing compared to your native or index TAVR, where we can go quickly. Then this is the overall literature review about the same, whether valve in valve, and when you do a redo surgery, they go through the individual mechanism. This is a nice paper, outcome of redo TAVR versus surgical explantation from USA. Where we want to know what is the latest data. Of course, most of the time, as we said, up to 1 year, is still favors the redo TAVR. After 3 or 5 years, we do not know because those data are not available. And they have clearly that when you do redo TAVR is adequate sinus dimension, low coronary obstruction risk, favorable prior valve platform. And explantation you do when coronary sinus anatomy is prohibitive, chances of the coronary obstruction and under expansion. And infective endocarditis, and of course the unfavorable leaflet and coronary relationship that you have trouble, those patients should go for surgery. So let me just complete both structural and non-structural valve degenerations are common. Common means does occur. I mean, it's not common, but these are the one which cause the valve dysfunction. And we learned that usually starts after 6 years. So average time of the structural valve degeneration is about 6 years. You are early, like this case is early. Patient prosthetic mismatch, PVL will present within 1 year or 2 years, but 6, 7, 8 years is there. So it's safe to say to the patient that this valve will last around 6 to 8 years. In the past, we used to make claim 10 to 12 years. I think more and more data are coming that you start having some trouble with the TAVR valve. Exceptions are there that about 6 to 8 years. So we have started changing that word to the people now. So basically, structural we have spoken about and different mortality, and so the redo TAV procedure require careful heart team approach and looking for the coronary risk plane, very, very important, and set anatomic clinical determinants of favor TAVR explant versus redo, we've spoken. And lastly, numerous strategies are being explored to retard the TAV degeneration, such as improved valve design, better anti-calcification treatment, decellularization, genetically engineered biomaterial, and role of anti-inflammatory as well as immunosuppressive therapies are being targeted into the small series and so. So let's go to our quick 3 questions. Following are the potential causes of structural TAV degeneration after TAVR except PVL, calcification, detachment, and fibrosis. Remember, PVL is non-structural. It's not a structural. Second, redo TAV is associated with a similar outcome as of native TAVR, except higher repeat aortic valve reintervention, similar post-procedure aortic gradient, similar death rate, and similar PVL at 1 year. And clearly, B, similar post-procedure aortic gradient, no, because it's a higher. And the lastly is that explant or redo TAVR registry comparing the types of valve and treatment type between redo TAVR or TAVR explant showed the following. Redo TAVR has similar 1 year outcome for structural valve. TAVR explant has similar 1 year mortality for structural versus non-structural, similar time interval for redo TAVR versus TAVR explant, and most studies are shown higher 30-day and 1 year MACE after TAVR explant versus redo TAVR. And clearly we know the answer there is C, is not a time interval similar. Redo TAVR happens versus TAVR explant, and so more important is also we wanted to show that BroadMed AV is our preferred vendor which have been working with us for last 15 plus years, and all this beautiful transmission, and particularly when we have the live relays, everybody compliments us for the excellent job the BroadMed AV does for our live transmission. With that note, I'll stop here, and Pedro, if any questions, or you conclude.
We have no questions at the moment, and thank you so much for the team and for you, the audience, to be today with us in this exciting case. Remember, you can review it as long as this afternoon. You can see it this afternoon at ccclivecases.org. And finally, our structural half-life cases occur every month on the second Tuesday of the month. It will be at 9 a.m., July 14. See you there. Thank you so much.